in the sense that he's done things people cannot explain. Tammy Duckworth.
Thank you very much.
Black Hawk helicopters
It's a real pleasure to be here, and I want to tell you a much more lowbrow story than we've heard this morning. It's more about a culture of data analytics and how Intermountain Healthcare have built into the fabric of their organization, the fabric of their operations, and the culture of how physicians and nurses and other people that take care of patients at Intermountain Healthcare,
and then in 2009,
the culture of analytics and leveraging data and information that come from data to improve the quality and improve the outcomes that patients would care about, improve the cost of care. So today I'm going to talk about how Intermountain over many decades has built a culture of eliminating waste, sustaining some of the lowest costs per capita in the nation, and they've done it by leveraging data analytics. So that's what we'll talk about. This is one of our slides that we like to show because it puts Utah in the best position. I'm sure there's plenty of other slides out there where we're not in the best position, but this was from the United Health Foundation in 2012, a ranking of healthiness versus total health care cost per capita. And so the farther on the right side of the graph you are in your state, then the healthier your population is, and the higher up on the graph you are, then the more affordable health care is in your state. And of course we like to show that one because Utah's up there in that upper right quadrant. This was another one of our favorite show-off articles from Time magazine several years ago that talked about how expensive health care is. It's a different way of looking at similar data that was shared this morning, showing that the United States and Luxembourg are pretty close together in the amount of money we spend per capita in taking care of people. And then if you look, especially we looked at this little graph down here, looking at the disparity among the states and among regions of the country and how much we're spending per capita, with Washington, D.C. being the highest per capita at this time, the time of this study, and Utah being the lowest. And it turns out that if everyone in the United States practiced medicine as it's done in the state of Utah, then the cost per capita would rank somewhere between Canada and France, and there wouldn't be a national financial crisis for healthcare. So how did this start? How did this happen in the state of Utah? It started with data geeks, and our chief data geek in 1953 was Homer Warner, who coined the term medical informatics in an article that he wrote before developing the first medical informatics training program. But the questions that Homer was a great guy. I met him before he passed. I knew him probably for about 20 years. And one of the things that he was found doing at LDS Hospital as a young fellow is that he catheterized himself and attached the catheter to a pressure sensor that was attached to an oscilloscope, and then ran up and down the stairs. This was in the late 50s. With
go now. You can go. Please leave.
The oscilloscope and trying
that was
to see
Senator Richard.
Could we monitor changes in blood pressure using the oscilloscope. And so these were the types of experiments that if he couldn't get funding or adequate people to experiment on, he would just experiment on himself. A wonderful individual to work around and be very creative in his approaches. But one of the foundational questions about using computers at Intermountain Healthcare, because of the time that it started, Homer didn't ask how can physicians use punch cards to record their clinician notes, or how can physicians use punch cards to enter orders. His questions were, how can we use computers and computer data to help clinicians make better choices? And that became a foundational principle of data usage at Intermountain Healthcare. That was the key to computers and what their value was. And we probably at Intermountain held on a little bit too long to that. As late as 2005, we had physicians firmly believing that physicians should never enter a note or place orders using a computer system, but that computers were for a different purpose. The next sort of advancement in the building of this culture came with another personality, a second personality, Dr. Bretton James, who was a Harvard-trained general surgeon, who had a fascination with research and with statistics, got a master's in statistics. He studied with Dr. Edwards Deming at Harvard, and Dr. Deming obviously was one of the foundational consultants for the country of Japan in the Toyota model that we heard about earlier today. Anyway, Dr. James joined Intermountain Healthcare in 1982 and brought with him a very strong ego and a great deal of passion for research and for being able to teach about the value of looking at data and improving healthcare doing that. And he began to take a look at what we could learn from all the data that we'd been gathering in Intermountain Healthcare over the previous 2 or 3 decades. And one of the things that was available to him was a cost accounting system, a system where the actual costs of care, not only the materials that were used for each patient, but the amount of time each different clinician spent doing certain procedures for each patient was available to him. And he began to do very focused clinical quality improvement projects around quality or around efficiency or around utilization of different elements within the healthcare system, and to use his training in statistics and data analysis to show improvement. He did some seminal work in the 80s around getting antibiotics into a patient prior to starting an abdominal thoracic surgery and showing a decrease in the complication of intra-abdominal or intrathoracic infections after the surgery, which are horrendous side effects of that particular type of surgery. His challenge was, cultural challenge within the organization, was that because of his strong physician training and the walls that we as physicians build around ourselves saying that we have an ethic that doesn't allow us to consider the cost of healthcare. He never brought the financial team to the table, never asked them to come and see what they thought about what he was doing. And so he continually focused on projects that saved lives or that decreased morbidity, but didn't look at the cost of what he was doing. What was the cost of the organization of the improvement? Was it a benefit or a challenge? And in the early 90s, he was presenting the results of a wonderful study to his colleagues, and the CEO of Intermountain Healthcare attended the meeting and said, "Brent, when are you going to stop doing cute little science projects and actually do something that matters?" And that was a very interesting statement to Brent because he was counting his successes in lives saved and felt that that did matter. But it made him take a step back and ask himself, why does my CEO feel like that doesn't matter? And what would we do differently if we were going to do something that mattered? So in the mid-1990s, Bretton James pulled in a doctor by the name of David Burton, who was really a genius when it came to organizational structure, and created an organization called Clinical Programs. These were, there's Brent, and let me see if I can get a picture of David up here as well. There's David. So they began to recognize the power of personality in building culture. It wasn't just about the data, it was about getting the right people in the room and focusing on the right projects. So David and Brent sat down with a team of data analysts and just began to ask some questions. One of the first questions they asked is, what do we do at Intermountain Healthcare? What are the processes that we provide to people? And they defined 1,400 separate clinical processes, individual clinical processes that you could point to and say, there's a team of people who take these resources and do this thing to people. And they do it over and over again. And then they identified, of those 1,400 key clinical processes, and later I have a slide, I put it in the deck so you could have it going home, but what are the elements of a key clinical process? Well, a key clinical process is high volume. There's a lot of people that experience this process. It's not 10 people in a year. It's something that happens to multiple people every day. Number two, the process is high risk to patients. In other words, there's a high risk of morbidity or mortality, or there's a high cost of that particular procedure. Number three, if it was going to be a process we worked on, it needed to be a workflow that we controlled. So did we own or have significant influence over the people that provided that process within our organization? That was the third piece. Did we own the clinical microsystem, the clinical team? And number fourth, could we detect using our data and analytics techniques that there was a great deal of variability or variation in how that care was delivered from hospital to hospital, from clinic to clinic, and from person to person? They came up with 104 key clinical processes and said, of all the things we need to do, we need to drive unnecessary variation out of these 104 clinical processes. And we will save more lives and more cost by doing that than by doing anything else. They engaged the clinical leaders. I'll back up here a little bit. So nursing leaders who had been in operations in cardiology, as an example. Dr. Mark Ott is another Harvard trained surgeon who is the chief of our clinical program around surgical services. Dr. Brian Oshiro was the head of our women's and newborns clinical program. And all of these people had a strong interest in improving healthcare in their own personal area of interest and research. But the change that was made is, instead of saying, what are you interested in, go after that and study that, they said, doctor, we need someone to approach these clinical processes that are key clinical processes within an organization. They began to organize themselves not around specialty, okay, but by these processes. So there was a new clinical program defined for women's and newborns clinical processes. And these people were not just the obstetricians or the gynecologist. It was any clinician who had anything to do with women and newborns and that entire process. So pediatricians, family physicians, nursing, pharmacy, all of the different types of, perinatologists, neonatologists, all of the different types of clinicians would come to the table. The next thing is that the principle of transparency of data and analytics for these groups, not from the central team or for a higher up team looking down and saying, we're going to use this data to belittle you. In other words, we're going to take the bell curve of behavior. We're going to find those that are the outliers on the bad side of behavior and fire you. That's how we're going to improve? No, that's not the way to do it. The way to do it is to show the team transparency and simply ask the question, why do you think there's this much variation in what we're doing, and what are we going to do about that? So it's very important in transparency of data and data analysis to not use it as a punishing effort or a critical effort, but to use it as an interesting, intriguing question to bring people to the table. Let's go ahead and watch this. Now, before we start this video, this is Dr. Mark Ott. He's a general surgeon. He started his position as the head of surgical services, clinical programs at Intermountain Healthcare about 5 years ago. And when he came in from Boston, he had no interest whatsoever in the cost of healthcare. And I want you to watch this video. Not so much, watch two things in this video. One, it's a really cheesy video, so don't watch that. It's really, really bad. It's terrible. Okay, but watch the outcomes, and then think about how engaged Dr. Ott is in this. So let's go ahead and see if we can watch this. I'm not sure I'll be able to. It's a YouTube video.
Outline the supplies and tools surgeons prefer to use in a procedure. Like world-class chefs, doctors have their own special ingredients they need to perform surgery. They can be very particular about their supplies. Learn how Intermountain Healthcare created a recipe for success to streamline surgery and save millions here on Healthy Dialogues.
And a very well-known study by Duckett et al. In terms of wait times in Australia.
2 years ago, Intermountain launched an initiative to help physicians and staff be aware of the costs of the items on their procedure cards, understand their range of alternatives, and easily make changes in real time.
What do you
Called
say
ProComp. This initiative saved more than $16 million in the first year, and more than double that last year.
It's actually
To start
interesting
ProComp,
because in fact
support staff
the
analyzed
people who
data
are
from
the
surgical
pioneers
procedures
of
to
that
determine
particular
what supplies the
surgery, which
physicians were
Premier
ordering
Williams
in comparison
had,
with one another.
and had the best
What we
health,
learned,
outcomes
there
in
was
the
a
world
big
for
range
that
of preferences
surgery
and
are in
cost.
Toronto at the,
Imagine
at
one
the
doctor
cardiac
charges
center just down the
$700
street
to
from where I
perform a
work.
tonsillectomy,
So what I say is
while
that
another
sometimes
charges
people have a
$565.
perception,
Both have the same
and
outcome.
I believe that,
The
and
only
actually
difference
this
is that
fueled
one
in part
uses
by,
an equally
media
effective
discourse,
but more expensive
that going
surgical
to wear
tool.
something where
Is
you
this
pay
cost
more
necessary?
for something, that
Some doctors may
necessarily makes
argue
it better, but
yes,
it's not
the
actually
time
borne
saved
out
and the features
by
of the
evidence
tool
on
make it
outcomes
worth
of
it,
that
while
cardiac
others
surgery or
disagree.
any other.
So how do you get the physicians to evaluate the data and potentially change what they've been doing for years? The answer for us, transparent, meaningful data. To get physicians on board, we pursued 3 tactics. First, we collected data from doctors, including the costs of supplies used and correlating patient outcomes. This allowed doctors to see for themselves if the higher cost is justified by the outcome.
And what we've
Second,
found is that
we presented this
actually
data to the
working within
doctors
the
with
single
full
payer system, we
transparency.
can
In the
reorganize
past,
things.
it's
I
been
waited
culturally
more than 30
expected to
minutes
keep
at the
this
security line
information
to get into this
anonymous.
building
By
today.
including the
And when
physicians'
I arrived
names
in the lobby,
next
I
to the
noticed
data,
across the
the
hall
doctors
that there
not
was a
only took
second
full
entry
responsibility
point
for
with
their
no
work,
lineup whatsoever.
but they could see
Sometimes
who in
it's
the
not
group was
actually
giving
about the
quality
amount of
care at a
resources
lower
that you
cost.
have, but
A
rather
doctor
about
would
how
then
you
go to
organize
those who were
people,
excelling
in
and ask for
order to use
advice,
your cues most
how they
effectively.
could
And
do
that's
it
what we're
too.
working to do
And
because
third,
we believe
we
that when
continue to
you
involve
try to
physicians
address
and
wait
harness
times,
their
you should do it in a way
expertise
that
in building
benefits everyone,
programs to
not just
support
people
our
who can
initial
afford
ProComp
care.
efforts. Since its launch in 2013, Intermountain physicians and staff
I
have
don't,
become
sir, but I know
avid
that
supporters
there
of
are
ProComp.
45,000 in
They've
America
adjusted their
who die
procedure
waiting because
cards
they
to
don't have
reflect new
insurance at
learning.
all.
And all these changes really add up. With more than $100 million saved since its inception, these savings are passed right along to the patients. ProComp is just one example of how Intermountain provides high-quality care at an affordable cost. To learn more, subscribe to our Healthy Dialogues YouTube channel.
They obviously should not quit their day jobs, you know, the
Okay.
smiling.
You got a big problem here.
You know,
if you're going to attack the financial
$100
system,
million
the
since
bankers and the fat
2013
cats,
saved
you're
in
using
Intermountain Healthcare in surgical
a person who's
services
exploited the
simply by allowing physicians to see the data about how much their procedures cost, line item by line item, and then share that data, not so that senior managers can come in and say, what the heck is going on, but so that they can look at each other's data and say, what are you doing? How are you improving this? Fascinating procedure. So, again, these are the key clinical processes. I've talked about that. That's in the data the slide deck so that you can take a look at it later. I want to kind of highlight what quality improvement at Intermountain Healthcare is and what it isn't. It is not a focus on external reportables, things that we have to report to CMS or to the Joint Commission or to our Medicaid partners in the state or other insurance plans. We do those things. We have expensive staff people. We have data analysts that are helping us to find the data, crunch the data, and report. But we find that most of that work does not improve care in our organization. It doesn't improve mortality or morbidity or cost per se. Most of that work adds jobs in the state of Utah to the people that need to come and do that work, and takes a lot of expense to do it as well. What quality is at Intermountain Healthcare is to follow outcomes that patients would care about in our key clinical processes. And we start with looking at the medical literature and asking the question, what are the best ways to take care of this particular process? But then we move to following the data. We start with looking at the data of a baseline of care. We implement a shared baseline of care, and then we follow the outcomes of the approaches. How do we implement a shared baseline of care? That's another challenging cultural thing. In the 90s, this was called cookbook medicine. It was very unpopular. The way we do it is that we don't ask physicians to adopt an outside guideline. We ask them to create the shared baseline of care with us. People from our flagship hospital all the way to our acute entry hospitals are invited to come to the table and to create the shared baseline of care. Number two, that we demand that our clinicians step away from that shared baseline of care as needed by their patients, because we recognize that it's almost impossible to write a protocol that will serve correctly every single patient. And so the thinking nurse in the room, the thinking physician in the room, needs to deviate from that shared baseline of care as needed by their patients. We don't try to do everything. We focus on the right projects. And we recognize that at some point, there's not a lot of value in getting better. You could put a lot of effort in moving the notch just a little bit more, but you add more and more and more expense for very little return gain. So getting to, one of the sentences that we use is, standard care is better than best care. And we prove that with data analysis. We know that that's true in our organization. We also bring other people to the table, statisticians, informaticists, finance and administrative support, and I'll show you a little bit about how we do that. To be able to do this, there are several things that are needed. One is an electronic health record that has coded, computable data. We have to be able to control the clinician-facing aspects of that electronic health record. And wherever we can't control that, then it makes it difficult to create and work from a shared baseline of care. We have to have access to the data. We have an electronic data warehouse that gathers data not only from our electronic health record, but from many internal and external data sources. And we produce data marts, or subsets of that data that are useful to these clinical teams. It's important to have the data analysts and the owners of the data that can understand how to, what the data do and don't show, what they do and what they say and what they don't say. And then we develop clinical teams, and I'll briefly go over that can focus on these data and develop these shared baselines of care. And then from a financial perspective, we've aligned our incentives towards the achievement of getting everyone to work from these shared baselines of care. So I'll talk a little bit about this organizational structure, and I think I have a pointer here. So each one of our clinical programs owns 2 to 10 of our key clinical processes. And each clinical program has a guidance council that's led by a respected physician in the community. We pay 1/4 of her or his time to come and lead that guidance council, and a full-time nursing operations officer from the organization who has a great deal of experience in operations. We have people on this team, including our information systems team, data analysts. We have people from finance. We have support staff to support the team. They understand which key clinical processes are assigned to them, and they create development teams of specific clinician experts and other experts that are needed from within the organization to focus on each individual care process, important, key clinical process. That development team will work in a pilot area to create a shared baseline of care. They will use data and data analysis to either prove or disprove that working from a shared baseline of care works and is effective. They transition that within our organization to a different clinical area to see if the shared baseline of care also produces similar results in other areas. And once that's proven, they have the option to feed back to our clinical operations leadership team the proposal every year that one of their shared baselines of care become a system-wide, or what we call a board-level goal, where the board that owns Intermountain Healthcare will be made aware that there's a goal this year for our organization to improve the mortality or the morbidity or the cost in this particular area using this goal. Then sitting on this guidance council are physicians and nurses from every region in the organization, and this is how we get grassroots buy-in and grassroots information feeding up to us about how this should work. I'll talk a little bit about our EDW, and I'm a simple physician, so this will be a simple, probably overly simple for people in the room, but there's a enterprise data warehouse that pulls in data from all of our different systems. We normalize, we encode, we use standardized terminology and terminology services. We have one dictionary of terminology that we use for all of our data. And we are also building data models to conform with international standards so that we can share our data with other organizations. Then like I said, we have a set of data marts that we present to our clinical program leadership These are the elements of data out of the EDW that they would find interesting. It's not everything. And then there are reports that can be made out of the data marts. So what about the people that surround the enterprise data warehouse? Well, there's a central team of about 40 people that do all the work of gathering this data, standardizing it, normalizing it, coding it, and doing the data modeling and things like that. Every clinical program has their own data manager who understands what data are available to them and what data they don't have, and they understand how to connect with and communicate with the central team in order to ask for the things that they need. And then every clinical program also has a set of data analysts. They have their own data analysts full-time employed, essentially, that can interact with the data managers. And these are the people that tell us what the data mean and create the information for the clinical programs leadership. So across all Intermountain Healthcare, we employ, with these types of people, we employ about 320 what we call data analysts. They take all these different roles. There's a central team, and then there are clinical programs data analysts, and there are also analysts in the regions and the hospitals to help them with their own data. So a couple of brief examples in the couple minutes that I have left. Back in 2004, the chief of our intensive medicine clinical program was very concerned about our sepsis rate. We were better than the average in the nation. The national average at that time, best that he could find, was 27% mortality from severe sepsis. The Intermountain rate was 24% at that time, or a little bit lower. But he was convinced that because we could not consistently provide, we could not prove consistently that every patient was receiving every recommended care in the emergency department or in the ICU, he thought our mortality rates could improve. There were a lot of arguments held about that, but he stuck to the data, saying the key principle here is that of the 4 elements that define a key clinical process, I can prove to you that we have variation in care. And because we have variation, we can improve. And so they began to put into their processes a shared baseline of care of how patients will be cared for in the emergency department and in the ICU. And basically what teams would track on the frontline team level is their behavior relative to a specific set of behaviors, and they would have data available to them immediately about how well they had done in complying with, we don't use the word complying, but how well they did in using that shared baseline of care. And you can see that over the years, as this became a board goal, our mortality rate dropped significantly down into about the 6 to 8% level. This saves about 125 lives per year at Intermountain Healthcare compared to how care was delivered in 2004, and it's of benefit financially to the organization of about $38 million per year. So again, the care process models, as I've mentioned before, of the 104 that we've defined as our key clinical processes, we have shared baselines of care in operation daily at every clinical environment where they should exist for 60 of those care process models. And this is work that we've done over the last 20 years. So we still have quite a ways to go, but we're currently moving from our homegrown HELP and HELP2 systems to a single instance of Cerner as a system-wide electronic health record. But we know, and we have data to prove, that this approach saves millions of dollars, hundreds of millions of dollars every year, and saves many hundreds of lives every year compared to the care we were delivering prior to this process. So I'm going to wrap it up there. We'll save questions for the panel later, but you know, having teams of people that understand data analysis, that are well integrated with clinical leaders who are focused on driving unwanted variation out of care has been extraordinarily effective in Intermountain Healthcare. Thank you very much.